We're going to show you this week about how to simulate a breast the old way. What you want to do is initially when you're doing these, you're going to have the patient, just like when you treat them, have the patient on the side of the table that you're treating. So if it's a left breast, left side of the table. We want to be able to clear the table with all of our readings and not have to like treat through the table or take films through the table. Get the patient on the table, and you want to get her straight with the laser, right from SSN all the way down through here, xiphoid, all of the same stuff we do every time. Since we are doing a breast, you want to have the neck, have the face turned. If you're treating the left side, have the patient look to the right. For two reasons. Say they've got a really big breast, they're kind of up in their neck, and their chin is down. You could treat through their mouth. Number two, doctor decides, oh, I wanted to do a super clap, but you have the neck like this, you got to send the person completely over again. Have the person turn their neck away from the side to be treated in case you want to do a super clap, and so you don't treat their mouth whenever you're coming in with this angle. So, having said that, we do know that our entry and exit points are something like this. You're going to have, the entry point is usually going to be mid-sternum. The entry exit point from the lateral is going to be down the mid-axillary line. That's kind of where I have the lasers. The first thing you want to do whenever you do simulate a breast is to ballpark the person in the correct location. We've talked about this before, but we're going to do it again. Ballparking the patient up, down, you're going to drop her so that the laser falls halfway between the mid-axillary line and the anterior flash. You have two equal portions right here. Then you're going to move the patient laterally such that hopefully, if your table's not stuck, you're going to move laterally such that the laser and the field, in this particular case, are halfway between the midline and the lateral flash. I'll turn the field light off so you can see the laser right here. That laser bisects the breast. Obviously, not every woman is going to have the same breast as Pixie. It could be laying off over here. It could be perky like hers. It could look like her chest. But you want halfway between the midline and the lateral flash and have that laser just cut right through there. And once again, two equal parts. So essentially you've quartered her breast area. 1, 2, 3, 4 quarters. Now that you have the patient ballparked, you're going to rotate the gantry off about 45 degrees. Once again, I don't have the I'm going to stop right there. I don't have the eye image intensifier out. I should probably put that out in this particular case. But as you can see, this is about what your gantry angle kind of looks like for most breast treatments. I apologize. Give me a second. It's important to have the image intensifier out so that I can demonstrate some of the pitfalls that are going to come your way when you do simulate a real breast on a real simulator. So I'm going to go ahead and turn that field size on. You can see when I rotate it around, I don't have a field size set or anything. I want my entry point to be such that it's right about at the mid-sternum. You also want to then open your field size such that you have flash about 1 to 2 centimeters across this way, and you can see the flash on the image intensifier. And then you're going to have the field length such that you have 1 to 2 centimeters inferior to the inframemory fold. Superiorly, you're going to go to the I've suddenly blanked on the name of the joint. You're going to have your sternoclavicular joint. Sternoclavicular joint. Basically, if you aim for the SSN and then have your flash along there, you can even see the divergence going along here. You see the divergence in both axes. The superior edge of the breast tissue is usually about the sternoclavicular joint. What's usually going to happen, though, is the doctor's going to come in and he's going to actually put marks on the patient where he wants the entry and exit point, where he wants the superior and inferior aspect of the patient to be. I'm just pretending I'm the doctor and I'm going to do all of this. So, sternoclavicular, 1 to 2 centimeters, 1 to 2 centimeters of flash. So I'm going to go ahead and put some marks on the patient, and we're going to pretend that I was exactly right. The doctor said, right about there, right about there. And then lot. So he just put some marks on. Once, huh?
Show this one.
Right there. I've got the image intensifier in the way. If we let me move the eye a little bit so we can actually see our back pointer laser. Okay. Back pointer's coming across here. So what we're going to do is we're actually going to rotate a hair and raise the patient a hair. Now, back pointer laser, CR. We've got our entry and exit points, there and there. What you will then do is you're going to have 2 wires, one fat and one skinny. Sometimes you can use twisted wire for the fat wire. You're going to put the fat wire on the lateral. I can't reach my tape right now, but you're going to put your fat wire on the lateral, and you're going to put your skinny wire on your medial. You're just going to lay it right across and do the same up here on the medial. What that is going to do, that's pretty good. What that's going to do radiographically is demonstrate when you have both the wires crossed, then you'll know that both your entry and exit point are parallel opposed to one another. If you'll recall, treating a tangential breast is no different than 2 laterals. It's just tilted, okay? And so if you have a bilateral whole brain that's midline, you know that at 90 and 270, your CRs are crossing. You don't know exactly what your gantry angle absolutely has to be to radiographically show where these 2 wires will cross. If you don't have the correct angle, the wires will not overlap one another. And then you'll rotate until, what you'll do is you rotate the gantry until they superimpose on one another. Once they're superimposed, you know you're parallel opposed at the doctor's marks. That's the important thing, because the doctor wants to treat to a specific depth. He wants to treat a specific amount of tissue. So you're going to use these wires to radiographically show, do I have the gantry angled correctly? Now, if we have the back pointer laser running right across this wire, and you have your CR running right across this wire, we know we're going to be pretty stinking close. So, we've got our ballpark, we've got our wires, we've got the doctor's marks, we've gone from the sternoclavicular to the flash to the flash. Now we need to go fluoro. So we're going to go out of the room, we're going to fluoro, and we're going to look at these wires and make sure that they are superimposed with each other. If they are not superimposed with each other, you'll rotate the gantry a little bit until they are. And then from your perspective, if they are on top of one another, your gantry's angled wrong. So you angle your gantry until they superimpose from your point of view radiographically. And just like with the head and neck, we're using these wires to demonstrate the fact that we are parallel opposed and that our depth is set exactly where the doctor wants. So, if you have to adjust a little bit, do so. Don't move too much because you don't want to run the image intensifier into the patient. So, let's say we've done that. If the doctor likes everything and everything is cool, you're going to notate everything. Collimator field size gantry table. Come in the room, and you're going to actually mark your patient. I'm not going to do it right now because I can't reach, but you're going to actually lift the wire a little bit and put a little mark on the patient, put the wire back down. Read your SSD to that point. Once you've read your SSD, you've marked your patient, you're going to go out and you're going to take film. And just like before, you're going to set your film, you're going to set your TFD, you're going to center your image intensifier, and you're going to put medial left tangent for your field marker. Take your film, get it approved. Once it's approved, come back in, and you're going to go ahead and mark any other relevant field borders. Some would like you to mark everything, some will just do a little bit of superior, a little bit of inferior, some will just mark a CR. Either way, you're going to rotate your gantry. Once you rotate up a little bit, you're going to see the opposite side. You're normally going to have both arms up. Go ahead and give yourself a lateral mark on this side. Now you've got a 3-point setup, because we already have a dot over here that we were going to with this wire. Either way, rotate around to the equal and opposite gantry angle. Since you wrote down what that gantry angle is, you're golden. I didn't do that. I can't remember where I was. But I'm going to demonstrate how you don't want, what you don't want to do. As you come around, just like with other things, guess what? We've got a problem. You could ruin the equipment. What you now have to do is notate where your table is in space. My table lateral is 982.1. You're going to move your patient over, and then you're going to rotate your gantry, carefully watching both. Now, you can see we're clear here, but if Pixie had arms, we would have a problem up here. You don't want to tear her arm off rotating over with the gantry. So you're going to watch both. As we rotate, I'm not killing my patient, I'm not ruining the equipment, both of which are very important. Once we get clear of everything, we're going to go to our opposite gantry angle, and then we're going to make sure and move your patient back to where they were in the first place. You have to get her back onto her isocenter. Let's see, 982.1. Table keeps getting stuck. Okay. Now, we're going to say that that was our gantry angle. We are now going to read our SSD right here. That's about 89.7. How do I know that? I know it from experience, but we're going to pull it. It's actually 90. Look at that. You're going to take the wire off. You're going to mark the CR and put your wire right back on. So we've got a CR, we've got an SSD. Take your other film. Once you've taken your other x-ray, you've got them both approved. The next thing you need to do is get your separations. What we're going to do then, I'm actually going to rotate back up, patient back over again. We've taken our x-ray, we've got all the marks in the patient. Now we have to get separations. Don't tear her arm off, don't tear the equipment up. You can leave the gantry up here. You've already got your SSDs, we're all good. I managed to dig out a pair of calipers. So, we're going to use these ice pincher calipers. You're going to put one side on mark number 1, one side on mark number 2, and you're going to tighten up your calipers. That's your separation. Now take a measurement, divide that in half, minus 100. That gives you what your SSD should have been in the first place. I did this out of order. This is something you should do before you take your x-rays. You should do this once a year, you leave things out. Once when you're at your medial, and when you first put your wires on, take your separation then. I'm sorry for having this out of order. Take your separation before you take any other films, any of your films at all. Make sure that you've got your isocenter set correctly. Okay? So set your SSD where it's supposed to be and then start taking films. I apologize so much for forgetting that.
It just makes it faster. It doesn't make it wrong.
Well,
I mean, you'll get to the same place by watching where your wires cross and all that.
I just like doing things in the right order.
Yeah.
So, but anyway, that's where you take your separation, entry and exit points, measure that distance, divide in two, minus 100, you're going to get your SSD. If your SSD is going to be within a half, most likely when you do that anyway, you may have to stair step up or stair step away to get to the proper SSD. Either way, the concept of where your entry and exit points are, how to ballpark, why you do your wires, you need to overlap them and have your entry, have it such that you're parallel opposed. You're demonstrating the parallel opposed gantry angle with your wires. Wires of different thicknesses and always doing the same thickness of wire in the same place so that everyone knows exactly which wire is where is also very important. Sternoclavicular, flash inferior, flash anteriorly, entry point post medially, I should say. Those are the big things to take away. The only thing that I would have to add, if you're going to have a 3-field added to this, I'm going to go back over and we're just going to, just really quickly, it's kind of a review. When you are at your medial angle, we already demonstrated the fact that you've got a lot of divergence to deal with up there, and we can see that. If you add a superclav onto this, you're going to add a 3rd wire. You will start with the superclav, anterior or 15 degrees off. You're going to encapsulate that field size as the doctor wants. It's going to be midline, include the supraclavicular out to the humeral head, and the CR will be at the inferior portion of that because half of that field will be closed down. Just like with the head and neck, you're going to lay a wire across that match line, and then what I'm going here, what I will do, we're going to pretend that we did that superclav already, and that our wire runs like this. You can see that we've got divergence problems. The way we fix divergence problems when we treat them and when we simulate them, you're going to kick the table away from the gantry. Kick the feet away from the gantry. When you do that, you can now match that non-divergent line by having a table kick. So that was about 4 degrees off. We kick the table such that she is now lined up with the superior divergence of that field. We would do all our normal stuff that we did before. We were just matching to that wire. Now, on the wire, all that is doing is demonstrating where that match line was. We're not trying to kick it until we are overlapping a U. We can actually see the divergence straight across here. You're actually just eyeballing it, and then you're going to show the wire versus the top of the field are overlapped on one another. You may have to kick the table a half degree one or the other. Eyeballing it versus looking at it radiographically are two different things. So you want that wire and the superior edge of your field to line up radiographically. So when you look at it on fluoro, you may have to kick the table a little bit one way or the other. But that match line will now be established. So you will do your normal marking and go on with your tangents. It'll just be with a table kick. Remember, do this side, rotate over, don't crash, don't kill, mirror your table. We're 4 degrees off this way. When you go to the lateral, we have to be 4 degrees off in the opposite way. With the head and neck, you have to have the feet to the gantry. With a breast, you have to have the feet away from the gantry. It's flipped over backwards from a head and neck. All you've done is flip the pancake. So you're dealing with the opposite edge, you have to do opposite things because your divergence is upside down from what it was before. Is that confusing? Okay, so kick the table, mirror the table, don't crash, don't kill. Those are the things that you have to remember. All the rest of it is the same. You just have to deal with the table angle versus the superior field edge that you're having to just eyeball and show radiographically with a wire that your superior field edge and your wire are not diverging from one another. They're overlapping and superimposing. As long as I didn't leave anything else out, that is a breast simulation. Thank you very much.